the 3-year and 4-month-old boy. The clinical diagnosis was congenital myopathy. So he had motor developmental delay, and the fetal development was decreased according to the mother. And so he was really severe condition in neonatal period. He needed feeding support and floppy infant. And he somehow was survived, but at 3 years old, he was at a regular checkup. He was pointed out that he was unable to jump, climb upstairs, or run, right? So he's like a kind of floppy infant with some problem. Intelligence is normal, facial muscle weakness, narrow high arched palate, hypotonia, proximal weakness, Goward sign, and decreased tendon reflexes. CK 34. Yes. So when I ask physicians how about CK, they often say, normal. Is this normal? This is low, right? Yes. So that's why I want you to tell us real CK value rather than just say normal. Because this is a congenital myopathy, but in congenital myopathy, not all cases, but often CK is low. Okay, and this can be also the clue for the diagnosis. Okay, so the muscle MRI shows atrophy in some muscles. Okay, I'll show you H&E. Looks normal, right? Fiber size variation mild, no endomysial fibrosis. You are already an expert in endomysial fibrosis. No, nothing. And myonuclei are located basically at the periphery of the muscle fiber. So it looks normal. But if you look at modified Montgomery trichrome, then yes, what are they? Nemaline bodies. So of course, you already have diagnosis. On NADH, of course, this does not that much contribute to the diagnosis, but you can see the pattern of the myofibrillary alignment is disorganized because of the presence of nemaline bodies. And if you look at the myosin ATPase, actually almost all fibers are type 1 fibers. Very strange. We are supposed to see checkerboard pattern, but no checkerboard. And actually, there are some type 2C fibers. Actually, most of them are type 2C fibers. I already confirmed. So it means that almost all fibers are type 1. This is extreme type 1 fiber predominance. And as I mentioned, type 1 fiber predominance is often seen in congenital myopathy, including nemaline myopathy. Yep. So this is nemaline myopathy. We already confirmed the diagnosis by genetic testing, ACTA1 mutation. This is a kind of typical presentation of nemaline myopathy. Okay, so I will go as quickly as possible. Next case, this is an adult case, 67-year-old man, clinical diagnosis, polymyositis. Of course, I will never say polymyositis, but the clinical diagnosis was polymyositis. Muscle weakness, myalgia. Okay, so PTA means prior to admission. 13 months prior to admission, muscle pain, hip and legs when he was walking, and 10 months prior to admission, pain in arms. And 6 months ago, difficulty swallowing. 5 months ago, weakness in legs. Then he became wheelchair bound. And he lost 20 kilograms, right, in 1 year. And no family history, no skin rash, normal intelligence, no facial weakness, no dysphagia, but he has dysphagia and proximal limb muscle weakness. CK 118, this is normal, really normal, right? And EMG myopathy. This is, unfortunately, this is often the case. They just say myopathy. Well, what kind of myopathy, we don't know. Yeah. Okay, what is this? Yes, exactly. Perivascular atrophy. So the diagnosis is dermatomyositis, but no skin rash. Yeah, so what should we say? You know, when you ask physician, rheumatologists, they say that the definition of dermatomyositis is the myositis with skin rash. This is the definition of dermatomyositis, according to rheumatologists and dermatologists. no skin rash, but perivascular atrophy, then we have to fight with them, right? Of course, this is, for us, this is dermatomyositis, 100% dermatomyositis. But this is modified Gormley trichrome. Those fibers are darkly stained. On NADH, often they are darkly stained. But interestingly, and this is, COX is a mitochondrial enzyme. This is very sensitive to hypoxia. Yes, so if you actually have a chance to analyze autopsy material, often COX activity is diffusely decreased. So look at the periphery of the myofibers. Those fibers are darkly stained on NADH, right? Because NADH can, reflect mitochondrial activity as well. So it means that there must be a lot of mitochondria, but COX activity is decreased. This is very strange. So many people, actually previous generations, like my mentors, they thought that this may be, dermatomyositis is associated with hypoxia, or more specifically vasculopathy or vasculitis. Yes, so the vessel vasculitis theory was the major concept of the mechanism, for the mechanism of dermatomyositis in previous generations. Yes. Then, and on ATPase, we can see the fibers with the intermediate colors. On alkaline condition, we are not supposed to see any fibers with the intermediate color. All of them are type 2C fibers. So there may be some regenerating fibers as well. Then this is ABC, right? ABC is MHC class 1. So we had a case presentation from Vietnamese, right? Vietnam, I think that was from Ho Chi Minh City. So he said that, Dr. Phi said that, okay, actually, so MHC class 1 was highly, upregulated, darkly stained, but not like that. In dermatomyositis, perivascular fibers are often darkly stained, but while others are only mildly or moderately stained. But I'm not sure. They said that everything was stained. So I think you really need to optimize your staining condition. But anyway, this is very much compatible. And this is the most, important immunohistochemistry for the diagnosis of dermatomyositis. I don't go into the detail because of the time, but now the concept of dermatomyositis is greatly changed in recent, maybe in the last 10 years. So the Dr. Greenberg, Dr. Steven Greenberg in Harvard and Boston, he did genetic study to check, to evaluate what kind of genes are upregulated in dermatomyositis muscle. And he found that all the genes associated with type 1 interferon are upregulated in the muscles from dermatomyositis patients. But this is not the case in other muscle myositis cases. So this is clearly different. So he concluded that dermatomyositis is type 1 interferonopathy. And MXA is one of the representative type 1 interferon-induced genes. So, and this gene expression can be evaluated by immunohistochemistry as well. MXA is, of course, protein, but so the protein expression, MXA expression, is clearly seen in myofibers, especially in perivascular area, right? So this is 100% dermatomyositis. So with this MXA staining, now we can say, you can make a diagnosis of dermatomyositis without any clinical information, actually. If this is stained, 100% dermatomyositis. Okay? Then going back to clinical feature, no skin rash, right? Actually, there was a big, this was a controversial topic, actually. Even long before the condition called dermatomyositis sine dermatitis. Sine means without in Latin. So without dermatitis. So this is, of course, unacceptable for rheumatologists and dermatologists, right? Because their definition is myositis plus skin rash is dermatomyositis. But their, sine dermatitis means without skin rash. Of course, unacceptable. But this was very controversial, and nobody could confirm the presence. but by MXA, we were able to confirm it, right? MXA stain, but no skin rash. This is the cine dermatitis. And in our series, actually, 8% of dermatomyositis cases confirmed by MXA expression do not have skin rash, cine dermatitis. And most of them are associated with anti-NXP2 antibodies. And another important finding, this is already a classical feature, but the membrane attack complex is deposited onto the capillaries. Capillaries are present in endometrium, right? So this is also another important diagnostic feature of dermatomyositis. So this is 100% dermatomyositis in terms of muscle pathology, but maybe clinically, I don't know. So our diagnosis, of course, dermatomyositis, more specifically, dermatomyositis, cine dermatitis. Whatever they may say, this is dermatomyositis, okay, not polymyositis. Next case, 15-year-old girl, mitochondrial myopathy, clinical diagnosis, and chief complaint muscle weakness. So she has 9-year history. So at 6 years old, when she was 6 years old, she already needed handrail on when she climbed up stairs. And when 3 years ago, she was pointed out that she had her height is lower, much lower than usual, and also pointed out having generalized muscle atrophy. And at 14, ophthalmoplegia. And on examination, she also had ptosis. Ptosis, ophthalmoplegia, and mitochondrial disease, of course, CPO, right? Chronic progressive external ophthalmoplegia. That was the clinical diagnosis, actually. CK, normal range, but CSF lactate was very much elevated. You use different unit, but normally less than 20, actually 18 or 17, I forgot, but at least less than 20. That is normal range. So this is very high. Okay. So on H&E, you can already recognize ragged red fibers, many ragged red fibers. But ragged red fibers should be recognized by modified Gomery trichome, and they are red. That's why it is called ragged red fibers. And on SDH, SDH is there are 5 respiratory chain enzyme complex 1 to 5. Complex 2 is SDH. So this directly, reflect mitochondrial enzymatic activity. So you see all ragged red fibers are darkly stained. Actually, SDH is much more sensitive than modified Gomery trichome to pick up ragged red fibers. And interestingly, all those ragged red fibers are COX negative. So this is called focal COX deficiency. This I compared at the same place. That highlighted by asterisk, they are all COX negative, right? So this means that these particular fibers have more mutants, okay? More mitochondrial DNA mutants. And nowadays, we do perform double staining, SDH and COX double staining. So this is more clear. So because SDH is blue, COX is brown. So if both of them are positive, you are supposed to see very dirty brown color, but you see only blue color, right? So this is, then you can tell that this COX is absent in this particular ragged red fibers. Yes, focal COX deficiency. And on ATPS, you see some type 2C fibers, and of course the diagnosis CPO. Of course, clinically CPO, but this is very much compatible with CPO. Patient 4, 15-year-old boy. The clinical diagnosis is Duchenne muscular dystrophy. Okay, he was, well, the high CK level was incidentally identified when he was tested for something. And the maternal cousin have muscle disease. So sounds like X-linked disease. Normal intelligence, and the incidental hypercemia at age 15 is very strange. Yeah. But anyway, so the CK is very high. and muscle MRI. Well, and importantly, I think probably age is wrong. Should be much younger. Yeah, sorry. Then anyway, so I think that she was pointed out the some abnormality early. But anyway, CK is very high, and of course, if you suspect Duchenne muscular dystrophy, the first thing you do is MLPA analysis, which can detect large deletion. But it was negative, MLPA negative. Then the next step you do is sequencing to pick up point mutations or small deletions or small mutations. That was also negative. That's why he received muscle biopsy. But muscle biopsy, you see necrotic fibers, regenerating fibers, and myelin fibrosis. You are expert on this, right? So this is exactly the same as the pathology I showed in my lecture earlier. So this is compatible with, of course, but this is not the diagnostic, but at least this is muscular dystrophy. And of course, there are type 2C fibers. And what about immunohistochemistry? This is immunohistochemistry against dystrophin. So almost all fibers are negative, right? But some fibers are positive. How can we interpret this result? Very strange, right? If you have mutation in Duchenne dystrophin gene, all should be negative. But why some are positive, right? This is very confusing. This is DRP2 is eutrophin. Eutrophin is normally not expressed in muscle fibers, but the structure, protein structure, is very similar to dystrophin. So when you don't have dystrophin, this is expressed to trying to compensate dystrophin, absence of dystrophin. So in fact, if you look at very carefully, actually in some fibers, this dystrophin expression is very, very poor. Okay. So in these fibers, dystrophin is actually dystrophin is present. Yeah, I compared. Yeah, for example, that particular fiber, dystrophin is positive, right? And eutrophin is negative. So this is like a trade-off. Yeah. And in fact, we found very complex mutation in deep intronic mutation. Yes. Anyway, so nowadays, to identify this type of change, you need to do RNA sequencing and also, targeted long read sequencing. It costs a lot, but to really make a diagnosis, you need this type of analysis. Number 5, I still have time. Number 5, 4-year-old boy. The clinical diagnosis was congenital myopathy. And again, fetal movement was decreased. And in neonatal period, he was very sick. He needed support for tube feeding, and the cries were weak, and he was floppy. He also had scoliosis, and motor development was delayed, and he obtained head control at 7 months, sitting alone at one year, after 1 year, and no further development until for age 4. CK is low, but not as low as previous case, right? Okay, and muscle CT atrophy in thigh, but sparing rectus femoris. Actually, this one is almost diagnosed. So for imaging expert, yes. Look at this. You are expert on endomyelial fibrosis, right? I know you already noticed endomyelial fibrosis. Very good. But no necrotic or regenerating process. This is very interesting, right? In muscular dystrophy, you have necrotic and regenerating process, then finally endomyelial fibrosis comes. But this one, no necrotic and regenerating fibers, but diffuse endomyelial fibrosis. So this is the mechanism should be very different from muscular dystrophy, right? And modified Goldman trichome, the endomyelial fibrous tissue is much better highlighted. Then this is the diagnostic. Yes, central core disease. Unfortunately, the core is not as beautiful as the one I showed. Yes. But this is also central core disease. probably if we do muscle biopsy a little bit later, like 6 years or 7 years, most likely they will have more clear cores. We actually did a very interesting study. If we, biopsy very, very early, like before 1 year or something, actually there is no core. But later the core comes. Yes. So this is probably, that's why the border is not that clear. But anyway, this is central core disease, right? You are already an expert. And this one, see, ATPase. We are supposed to see two colors, right? Only one color, only vessel shows color. So it means that all fibers are type 1, okay? And this disease, actually, central core is emphasized. But probably this is more important phenomenon, most likely, because core comes later. But the patient was sick from the beginning. So if you do biopsy early, we see only this one. So probably this is more important mechanism. And this is caused by mutation in ryanodine receptor gene, RYR1 gene. Why it is called ryanodine receptor? Ryanodine is a poison, okay? And so pharmacologically, so the previous researchers trying to identify why this is toxic or, to human. Then they found that ryanodine attached to one molecule, calcium channel. And that's why this calcium channel was named ryanodine receptor. But this ryanodine receptor is a calcium channel. So, when muscle contracts, actually small, of course we receive, electrical signal from motor neuron, then it, runs on the surface of the muscle fiber, then come in. Then finally, this signal opens up the channel, calcium channel, and calcium from the sarcoplasmic reticulum will be released every time when muscle contracts. So this calcium release is important for muscle contraction, okay? And they found that this ryanodine actually blocks this channel and calcium cannot go up. Well, this is the mechanism, okay? And central core disease mutation is present exactly at the same place where ryanodine interacts. And there is a very interesting experiment. I know Vietnamese and also other Southeast Asian people consume a lot of chicken, right? Chicken, you don't have any religious problem, so you consume a lot of chicken. Many, but of course not everything, but often chicken muscle is white muscle, right? So some guy, did culture or chicken muscle, or this is white muscle. But if you add ryanodine, right, ryanodine and culture, all muscles change to red muscle. Type 1 fiber means red muscle. The mechanism is probably the same, right? Because ryanodine, the RYR1 mutation is exactly the same place as ryanodine receptor, So probably in central core disease, calcium cannot be released very well and all becomes type 1 fiber. So mechanism is probably the same. Okay, so anyway, so this is extreme type 1 fiber predominance. And central core disease, we already confirmed the mutation. I have 10 more minutes. Maybe I can go through. 58-year-old male suspected to have motor neuron disease. But I have to tell you that to make a diagnosis of motor neuron disease or ALS, you shouldn't do muscle biopsy. This is not allowed. Yeah, so this is not a good example, but they did. So around 1 year ago, he developed difficulty buttoning and holding objects, and gradually became unable to raise upper arm and chopsticks, and ankle weakness, and developed muscle weakness. U is gone. Muscle weakness in this upper limbs. Okay, so anyway, so no facial and no problem, no dysarthria, no dysphagia, and CK is mildly elevated, and generalized muscle atrophy on muscle CT. See? Group atrophy, large group atrophy, right? And they are not really round, a little bit elongated, right? So this is acquired condition. This is another part of the whole, really everything is atrophied. Yes, large group atrophy, right? Yeah, so this is a modified common trachoma, NADH. And on ATPS, you are supposed to see checkerboard pattern, but the same fibers are, this is type 1 fibers are clustered, right? So there is fiber type grouping as well. So fiber type grouping means reinnervation. Group atrophy means denervation. So there is active denervation and reinnervation. They're compatible with ALS. I still have time. So 69-year-old woman, polymyositis. Again, of course, I will never ever say polymyositis. I mean, my diagnosis will never be polymyositis, but they say polymyositis, limb muscle weakness. So 1 year ago, she realized difficulty standing and swallowing, and gradually became unable to climb stairs, began to walk with support. Normal intelligence, no scapular wing, proximal muscle weakness. And CK, maybe upper limit, and muscle MRI, muscle atrophy in both quadriceps. You know this one, right? Endomysium, your favorite endomysial lymphocyte infiltration surrounding non-necrotic fiber. So if we just see this one, I must say polymyositis, right? But of course, we have this. So inclusion body myositis, exactly, right? Yes. Okay, and I will skip this one. And HLA-ABC or MHC class 1 is upregulated, much more stronger than dermatomyositis or something else. Yes. And HLA-DR or MHC class 2, we always, if you look for it, always see some fibers, positive fibers. Sometimes many, sometimes few, but always see 100% cases. Yes. And P62 aggregates. This means it's actually, this is equivalent to rim vacuoles. And CD8, all those surrounding lymphocytes are mostly CD8 positive. So this is, of course, inclusion body myositis. Okay. I did a great job. I have still have time for the last case. So 11-month-old boy, congenital myopathy, delay in development. So he was born by aspiration, and the Apgar score is low. So really, yeah, he's really sick, right? When he was born. So he needed intubation and ventilatory support, and he had asphyxia and marked hypotonia, generalized muscle weakness. You feel wow, so sick, right? And that at 2 months, he followed object, but no further development. So really, motor milestones are delayed or stopped. And yeah, and he only slightly can move his legs and arms. And facial muscle involvement, narrow hyoid, but this is very important to suggesting some kind of congenital myopathy. CK60, yes, low, but not very low, but still low. So kind of congenital myopathy is likely, okay? Looks abnormal, right? But no necrotic fiber. But sometimes you see fiber nucleus in the center, and they look very big, right? And you can see something dirty in the center, which you don't know, maybe. And looks like very unusual, but this is diagnostic. I showed you before. You see, on NADH, you are supposed to beautiful network even at the periphery of myofiber, but the periphery is empty, right? This is called peripheral halo. This is almost diagnostic of myotubular myopathy. In this one, again, almost all fibers are type 1, right? And the conclusion was X-linked tubular myopathy, we already confirmed the mutation. He had stop codon mutation. Okay, that's all. Okay.